that's a great question. So statins work on a different receptor that lowers the production and clearance of LDL specifically, or what is the sort of bad cholesterol that we talk about. Statins do not impact the production or clearance of lipoprotein a directly. And in fact, the impact of statins on Lp(a) is under some debate currently. Currently, testing for Lp(a) is used for risk stratification. We use it particularly in patients who maybe have a history of stroke or have a family history of early heart disease, or even if they have a family member who's been previously tested for Lp(a) and it's been high. And given that there are no FDA-approved medications for an elevated Lp(a), current management consists of lifestyle changes for any risk factors that might give somebody a risk for heart disease, as well as statin therapy. Screening for Lp(a) is not recommended currently. However, physicians can test for Lp(a) through the lab. It's not known right now if physicians need to test only once when they screen a patient, or whether it needs to be repeated over a patient's lifetime, like we do for regular cholesterol, where patients are screened every 4 to 6 years to see if their cholesterol levels have gone up. Unlike the majority of patients who have high cholesterol, Lp(a) has a strong genetic link, and it's actually unrelated to our lifestyle choices. So say a person who wants to lower their Lp(a) through diet and exercise, like they might be able to do with their regular high cholesterol, they cannot do that. So as well as Lp(a) has also been associated with coronary artery disease or heart disease, stroke, aortic valve disease, and heart failure. And these diseases can lead to a shorter lifespan or even complications later in life. For example, higher lipoprotein(a) levels have been associated with more heart failure hospitalizations. So certainly medications that target Lp(a) have the potential to impact how we screen patients for disease, as I mentioned. It's going to really change how we educate them about cholesterol. Typically we tell patients, if you modify your diet and exercise, you may be able to lower your cholesterol, but we know that Lp(a) is not modified by your lifestyle changes. So that'll definitely change. And then, of course, how we treat patients with high cholesterol is going to change. We might have additional medicines other than statins and treatments like PCSK9s to treat high cholesterol. So we may see that patients with an elevated Lp(a), treatment for lowering it may be part of guideline-directed therapy, in addition to other medications they need to take for heart disease, like statins and antiplatelet drugs. So I think we'll see a lot of changes if these medications come to market and are shown to be effective. For example, we're going to see guidelines change for cholesterol testing and screening. Physicians are going to need education around new guidelines as well as around the new medications that have come to market for a couple reasons. First, physicians might not be in the habit of testing for lipoprotein(a). In addition, they're going to need to learn about how to counsel patients around elevated lipoprotein(a). As I mentioned, that level is not modifiable by lifestyle changes, so that's a big difference. And then we may want to think about how we can leverage our electronic health record so that we can identify patients who qualify for testing and treatment to assist our busy physicians. We know they're so busy. We want to support them in developing a population health strategy to lower heart disease in their population. And then we're going to need a lot of education for patients around genetic factors like lipoprotein(a) that cause heart disease to help support adherence and persistence to future treatments. as patients begin to understand the impact that an elevated level might have on developing heart disease. And then finally, manufacturers can also be supportive. They can help develop patient support resources that can assist with patient education, helping physicians navigate prior authorization, and giving patients potential financial assistance to support medication adherence and persistence.